Hello, my name is Vivek Reddy. I'm a physician and a professor of medicine at the Mount Sinai School of Medicine in New York City. I'm also the director of cardiac electrophysiology at Mount Sinai Hospital. If you're watching this video, it means that you're interested in or perhaps you have atrial fibrillation. And so the purpose of this video is to provide general information about atrial fibrillation, both what it is, how we manage it, and what the options are. These cartoons depict what is atrial fibrillation. If you look at the image on the left, this is sinus rhythm, also called regular rhythm. This is what normally happens when you're not having atrial fibrillation. The top chambers are called the atria, the bottom chambers are called the ventricles. And normally, the normal pacemaker of the heart controls activation of the top chambers, and then in a coordinated fashion, you have activation of the bottom chambers. The image on the right depicts atrial fibrillation. What you see is a chaotic activation of the top chambers. And this is atrial fibrillation. And if you look at the top right chamber, it's also the left atrium. So the left atrium at the very top in red, that actually is where atrial fibrillation typically originates from. What's the problem with atrial fibrillation? Well, there are several potential problems, the most dangerous and important of which is stroke. Patients with atrial fibrillation have a high risk for stroke. And it's because of that patients typically require anticoagulation with warfarin or one of the newer medications, and we'll discuss other options. Another potential complication of atrial fibrillation is dementia. Patients with atrial fibrillation have earlier onset dementia, have a higher incidence of dementia, both Alzheimer's as well as non-Alzheimer's dementia. There are also a number of symptoms that can occur with atrial fibrillation. This includes palpitations, meaning that your heart is beating fast, shortness of breath, chest pain, oftentimes fatigue. During atrial fibrillation, you don't have quite as much energy as you would otherwise. It is also important to recognize some people have absolutely no symptoms in atrial fibrillation and are completely asymptomatic. The other really important complication of atrial fibrillation is something called tachycardiomyopathy. That means that because the heart is going so fast, the heart actually gets weak. What happens is when the heart is beating at a very fast rate for a long period of time, when I say long period, I mean weeks to months, then the heart muscle eventually gets weak, gets tired, so to speak, and can result in congestive heart failure. And this is a severe complication. The good news is that if atrial fibrillation is dealt with appropriately, then this tachycardiomyopathy oftentimes reverses back to normal, meaning the heart function oftentimes improves back to normal. So how can we treat atrial fibrillation? Again, when we think about treating atrial fibrillation, we separate stroke and we separate symptoms. So the first thing we do is to treat the risk for stroke, and the second thing is to treat the symptoms. We'll come back to the options in terms of preventing stroke. Let's talk about symptoms. There are two general strategies. In individuals with atrial fibrillation who don't have symptoms or who have very minimal symptoms with atrial fibrillation, the approach that we often use is rate control, meaning that we let the heart stay in atrial fibrillation, but we give medication that slows the heart rate. The other approach is rhythm control. So for individuals who have symptoms, that's the approach we typically employ, which means we try to get the heart back into regular rhythm. And there's three general strategies in terms of rhythm control. We can treat with drugs, we can treat with catheter ablation, or we can treat with surgical ablation. And we'll go through these. In terms of medications, there are a few different options. This graph represents the success of treating atrial fibrillation with different approaches. Placebo, of course, means no medication. It's just, for example, a sugar pill. The most effective medication we have that you see on the top there is amiodarone. But you see that even with amiodarone, after a year or two, only about half the patients remain free of atrial fibrillation. In addition to amiodarone, we have other options that are somewhere in between in terms of effectiveness, less effective than amiodarone, but better than nothing. These medications include flecainide, propafenone, sotalol, dofetilide, and Multac. There are different names for these medications. But the point is, these are all medications that are not quite as effective as amiodarone. Despite that, we tend to use these medications first. And the reason is that amiodarone has a lot of potential toxicities. It can cause problems with the lungs, problems with the liver, the thyroid. It can cause skin discoloration, and it can even affect one's vision. So we typically don't use amiodarone unless we don't have other options. what about the other options? Well, these medications may be appropriate for any individual person depending on the other medical issues that one may have. For example, if one has coronary artery disease or has had a heart attack in the past, then medications like flecainide or pafafenone can be quite dangerous because those can cause other dangerous arrhythmias. So which medication is best for one, for a particular person, really depends on the underlying condition and is something that you should discuss with your physician. Now, besides medication, the other approaches are ablation, catheter ablation and surgical ablation. I'm not going to speak about surgical ablation in this video. That's an option we typically reserve for patients who are already undergoing surgery for something else, like a valve procedure or a bypass operation. But in patients who are not already scheduled for surgery, catheter ablation is the option that we consider. What you see on the left that's rotating is a CT image or a CAT scan image of the left atrium. So you see the chamber itself and you see this tree-like structure which represents pulmonary veins. Pulmonary veins are the vessels that drain blood from the lungs and back to the heart. And what you see on the right image is an example of catheters, which are long wires that we manipulate in the heart, and we manipulate this into the left atrium and then place the ablation lesions. Now, if you look at this cartoon, what you see is the left atrium from the back. And you see the pulmonary veins, which are these four tube-like structures. And you can see this in this cartoon where the atrial fibrillation typically originates, which is within the wall of these pulmonary veins. You see there's abnormal tissue which fires and causes the atrium to fibrillate, and this results in fibrillation. How do we treat this? Well, if you look at the image on the right, this is the catheter ablation procedure. So what we typically do is to maneuver a catheter around the pulmonary veins in a point-by-point manner, and we cauterize the tissue. So the idea is to make a ring of scar tissue around each set of veins. Why do we do that? Well, so once this ring of scar tissue is created, while the blood can flow into the heart, the electrical impulses which cause fibrillation are sequestered into the walls of the pulmonary veins, and they can't travel into the rest of the atrium to cause fibrillation. Now, this is conceptually very straightforward, but technically it's a little bit more complex. If you look at the image on the left, what you see again is the image of the heart, and you can see an ablation catheter there. Right at the tip, you see the red dot that's being created. That's the ablation lesion. So that's the tip of the ablation catheter, the catheter that's actually used to deliver energy. And again, the energy we typically use is radiofrequency energy, which is what we use to cauterize the tissue. There are also two other catheters that you see floating around, and these are various diagnostic catheters that help us record electrical information, and we use that also during the procedure to help us. How does this work? Well, all the catheters are visualized by various mapping systems. These mapping systems are like GPS systems for the heart. So they can localize the catheter to millimeter resolution, so that can help guide the procedure in a very safe manner. As I said, radiofrequency ablation is the most common approach we use to treat atrial fibrillation. There is one other approach that's been approved in the United States, and that's cryoballoon ablation, which is you see on the right side. Cryoballoon ablation involves manipulating a catheter in the heart, inflating the catheter so it's a balloon-like structure. Then we push it up against the vein, and we deliver refrigerant inside the balloon to freeze the vein in one fell swoop. Cryoballoon ablation is also a very effective approach to treat atrial fibrillation. We tend to use radiofrequency ablation more frequently, but some patients we actually use cryoablation also, and it really depends on your specific medical condition, the duration of fibrillation, the other medical conditions that you may have. When you think about what happens after we treat atrial fibrillation, why do some patients recur? Well, this is the most common cause in patients who have intermittent atrial fibrillation. After ablation, what can happen is you can have a gap in an ablation line that conducts and causes fibrillation. So why does this happen? Well, during the first procedure, hopefully the only procedure, but during the procedure, the ablation lesions may not be completely intact, meaning that let's say there's a location where the tissue is extremely thick, or let's say the catheter wasn't manipulated properly and there's a small gap in the ablation line. Well, during the ablation procedure, that gap may not manifest because you may have enough swelling of tissue or reversible damage so that it looks like the vein is isolated. But a few weeks later, once it heals, you can have resumption of conduction and resumption of fibrillation. That's what you see on the right. Now, the good news is that getting rid of this is typically not difficult in a second procedure. We can identify these gaps very easily, place typically a single ablation lesion, and that isolates the veins. Of course, the bad news is that's a second procedure, and our goal is to do this procedure in one ablation only. Now, there's a second mechanism for recurrence, and that's what you see here. You could have another focus for atrial fibrillation here, or for example here, or even in the right atrium. And these triggers that are outside the pulmonary veins, if we don't ablate them, then they'll manifest and they'll cause fibrillation. Now, during the first procedure, we actually do try to ablate them. So after we isolate the veins, we give medications or we do various pacing maneuvers to try to induce these other triggers. Because if we can induce them, then we can ablate them and get rid of them. But sometimes we don't induce them during the first procedure, and we have to bring patients back for a second procedure. And during those procedures, if we induce them, we can get rid of the fibrillation. Now, I've been talking about intermittent fibrillation up to now. After people have intermittent fibrillation, typically the atrial fibrillation progresses to something that's more chronic or continuous atrial fibrillation, meaning that once the atrial fibrillation starts, it doesn't stop by itself and only can be stopped with a cardioversion or a shock to the heart. Now, this is important because when we're considering catheter ablation for continuous fibrillation, PV isolation, which is the procedure we've already discussed, is typically not enough. So once we isolate the veins, we typically have to do something else. And there are a number of different approaches to what else we have to do. Sometimes we make linear lesions. Sometimes we ablate these other sites called fragmented potentials. And ultimately, we can get the heart back into regular rhythm. Now, the problem is we can still have problems with conduction out of the pulmonary veins. And we could also have something else that you see here, where you could have these percolations of activity that are traversing throughout the chamber, going through gaps in ablation lines or between scar tissue that we create, as well as scar tissue that may already been pre-existing because of the atrial fibrillation. This results in something called atrial flutter or atrial tachycardia. There's different names for the same thing. But the important point is that these are rhythms that can occur after ablation for chronic atrial fibrillation, and they require a second procedure. In the second procedure, we again look at the pulmonary veins, we look for other triggers, and then most importantly, we identify these circuits that are traversing throughout the heart, and we ablate those also. Now, ablation of intermittent fibrillation or paroxysmal fibrillation typically only requires one procedure, but ablation of chronic atrial fibrillation oftentimes requires two procedures. So not always, but oftentimes. So we should just plan for two ablation procedures if we're going to go down that route. Now, what about the risks of catheter ablation? There are a number of different risks, and again, this depends in part on your specific medical condition, and so you should discuss this specifically with your doctor. But if we think about the four sort of major risks that are associated with catheter ablation for atrial fibrillation, these are the four: stroke, cardiac tamponade, pulmonary vein stenosis, and esophageal fistula. Why can stroke happen? Well, when we do the ablation procedure, when we cauterize the tissue, it's possible for char to form on the catheter, and if that happens, then that can then travel in the bloodstream, go to the brain, and cause a stroke. So how do we prevent this? There's two important things that we do. The first is that we always do the procedure on a blood thinner, meaning that you'll be on a blood thinner when you come into the lab for the ablation procedure. During the procedure, we actually use an IV blood thinner called heparin to keep the blood thin. And after the procedure, you absolutely must be on a blood thinner for at least 1 month and preferably 3 months after the procedure, and sometimes even longer. The second approach to decreasing the risk of stroke is the kind of ablation catheters that we use. You see, when we ablate tissue, as the catheter touches the tissue and heats up the tissue, that heat in the tissue can transfer back to the catheter and cause the heart to cause char to form, and then which can then travel to the brain and cause a stroke. But all the new ablation catheters, which we've had in this country now for about 7 or 8 years, all of these new catheters have a mechanism where we can actually inject saline down the center of the catheter, so we're constantly cooling the tip of the catheter. And this decrease the risk of stroke considerably. So while there is still a potential risk for stroke, it is extremely, extremely low. The second major risk is cardiac tamponade. That means that if we have a catheter and we're delivering energy into the tissue, and if we heat up the tissue too quickly, then that can cause a tear in the tissue and blood can leak out. If that happens, we have to numb the skin just underneath the rib cage and then drain the blood directly from that location. The key to this cardiac tamponade is recognizing when it happens, because if it's recognized quickly, it can be dealt with very quickly with no long-term problems. How do we do that? Well, one of the catheters that we use is an ultrasound catheter. So we're constantly looking at the heart so we can see if there's any blood that suddenly starts to accumulate outside the heart. Third complication is something called pulmonary vein stenosis, and this was typically a problem in the past when we didn't have as good mapping systems. Now in all of our patients we use various mapping systems, and we oftentimes will get a CAT scan or an MRI before the procedure in order to get a specific picture of the patient's anatomy. And the key is not to ablate too far inside the pulmonary veins. If we ablate too far inside the pulmonary veins, the veins can narrow, and if they narrow too much, then that can impede blood flow, and that could require an angioplasty later to open up the vein. The key to this, again, is to avoid this, which means to stay outside of the pulmonary veins. The last major complication is something called atrial esophageal fistula. Fortunately, it's extremely rare, but it can be quite dangerous. Atrial esophageal fistula can occur because as we're ablating on the back wall of the heart, where the esophagus runs just behind the heart, as we're ablating there, we can actually damage the esophagus significantly enough that a hole can form between the esophagus and the heart. And if that happens, then that can be catastrophic with massive strokes that can occur. Fortunately, this is extremely rare, and what we do to avoid this is we actually monitor the temperature in the esophagus. And if we start seeing heating of the tissue, we can stop ablation and go to a different, safer location. In fact, there's another approach that we're using at Mount Sinai where we can actually move the esophagus out of the way. And that's an approach that may be appropriate for you. Again, something to discuss with your doctor. The other last point I want to make is that while these complications and others can occur, the risk of any of these complications occurring is extremely low. Now, we're always trying to come up with ways to improve our ablation procedure. So I just want to show you in these next two slides a few examples. This is not encyclopedic. There are other options that we have. And in fact, these options may not even be appropriate for you specifically. But this just gives you an idea of the kind of approaches that we're using. So the image on the left describes one type of balloon ablation catheter, which uses a laser. What's interesting about this approach is that there's actually a camera inside of the balloon catheter, so you can actually visualize what's going on. So that bottom image shows you exactly what we're seeing during the procedure. The white is the tissue that the balloon is pushed up against, and the red is the blood that's flowing around. And that blinking green dot represents the laser that's being projected onto the tissue that actually cauterizes the tissue. So the beauty of this approach is that we can actually see where we're ablating, and we can make sure that the lesions are touching each other. The image on the right represents the mapping system, similar to what you saw before. The difference here is that the catheter actually has a force sensor. You see, normally when we manipulate the catheter, we can't actually tell whether we're touching the tissue with good contact in order to make a good ablation lesion. But these new generation of ablation catheters actually have force sensors, so you can actually identify whether or not you're touching the tissue and how much force you're touching the tissue. So that way you can optimize the contact with the catheter with the tissue. Now, both of these catheters are not yet FDA approved, but they are in clinical trials, which may be appropriate for you, again, to discuss with your doctor. Now, this next approach is not a new catheter, but it's a new approach. And this is called renal denervation for atrial fibrillation. This is a complicated story, but I'm going to go through this very quickly. You see, in addition to the nervous system that you use to move your hands and do voluntary motion, there's also an autonomic nervous system or an automatic nervous system that is involuntary. This is the same nervous system that controls the fight or flight response. And you have this adrenaline surge, for example. There's also something called the vagal system, which is also involved in this. Why does this matter? Well, this autonomic or involuntary nervous system is actually important in terms of the initiation of atrial fibrillation. So in addition to cauterizing the atrial fibrillation, we believe that by affecting the nervous system, we can affect both the trigger as well as the propensity for the heart to change and go into atrial fibrillation. So how does this work? Well, there are arteries that run to the kidneys, and what we do is we manipulate the ablation catheter to these arteries and place 3 or 4 ablation lesions in the wall of these arteries. And the reason is because there are nerves that run within the wall. It turns out that if we ablate these nerves, we can actually affect this autonomic nervous system, and we can actually affect the influence that this has on the heart in terms of going into atrial fibrillation. We like this approach because it's technically simple. It doesn't take a long time to do this procedure. Just for example, the normal AF ablation procedure can take anywhere between 2 hours and 6 hours, depending on the complexity of the procedure. This particular renal denervation step takes about 10 to 15 minutes. So it's a very quick procedure and a relatively small addition to the AF ablation procedure. It also turns out it's extremely safe. So this is something that we are doing as part of clinical studies at Mount Sinai Hospital, and something that may or may not be appropriate for you. Again, something to discuss with your doctors. Now, in addition to atrial fibrillation, one can have something called atrial flutter. Atrial flutter is something that oftentimes coexists with atrial fibrillation. So I'm going to go through this very briefly. There are 2 general types of flutter. One is typical flutter and the other is atypical flutter. Typical flutter is the kind of flutter that most often occurs, and it's a rhythm that's actually in the right side of the heart. There you actually see in this cartoon the circular rhythm going round and round in the right atrium. That is typical flutter. Typical flutter is a relatively easy rhythm to eliminate. It involves taking an ablation catheter, as you see there, and making a line of ablation between the tricuspid valve, which is the valve that separates the right atrium and the right ventricle, and this vein called the inferior vena cava. So what happens is when we place this ablation lesion, this line of block happens and this circular rhythm can't occur. Now I also said there's atypical flutter. Atypical flutter usually happens after ablation for chronic atrial fibrillation. I actually showed you a picture of that before, where because of the ablation lesions that we create, you can have this percolation of activity that's traversing around the atrium in some unusual fashion. So atypical flutter can be anywhere in the top chambers, and it's something that we have to do careful mapping of in order to eliminate. Both typical or atypical flutter can occur, again, with atrial fibrillation, and if you have these, we typically will do ablation for both fibrillation and flutter at the same time. Now, as I said in the very beginning, the most important complication of atrial fibrillation is stroke. And so one of the issues that we have to deal with in everybody with atrial fibrillation is how can we prevent stroke. There's 2 general strategies. The first, which is, again, the initial strategy that we use, are drugs. Now, the drug that we had in the past, in fact, the only drug we had in the past, was called Coumadin, also called warfarin. It's a drug that many of you are probably familiar with. It's a very effective drug in terms of preventing stroke, but there are problems with Coumadin. Coumadin is not an easy drug to take in the sense that it can interact with various other drugs and interact with different foods that you eat, so it can affect the tissue levels or the blood levels of this drug. It's also a drug that's not predictable in terms of its dose effect. So when one is taking Coumadin, one has to have blood draws at various times in order to make sure that the blood level is okay. If it's too low, the dose of Coumadin needs to be increased. If it's too high, the dose of Coumadin may need to be decreased. In addition to Coumadin, we now have newer drugs. Over the past 3 to 4 years, there's 3 new drugs that have come out on the market: Pradaxa, Xarelto, and Eliquis. And in fact, there's another one that's likely to come out very soon. The major advantage of these 3 drugs is the more predictable dosing of these drugs. So one doesn't have to have the blood draws. You don't have the same kind of interaction with drugs and with diet. So these are drugs that you typically take either once or twice a day, but you don't have to have any blood draws beyond that point. Now, these drugs are good drugs, and they may be appropriate for you, or you may already be taking these drugs. Again, something to discuss with your doctor. Again, while these drugs are good drugs, they're not perfect drugs. All these drugs cause bleeding, and you can bleed in various locations, including bleeding into the gastrointestinal system, or the worst kind of bleeding, which is, of course, bleeding into the brain, which can cause a massive hemorrhagic stroke. So there is another set of options in patients that are high risk for these kind of bleeding complications. This is the strategy of appendage closure. What are we talking about? Well, when one has atrial fibrillation, there's a structure called the left atrial appendage that's inside the heart, and that's where clots originate. And when the clots travel from that location, they can go to the brain and cause a stroke. This is a picture again of the left atrium. What you see on the right is the left atrial appendage. This is the blind pouch from where clots form in people with atrial fibrillation. Now again, we can use drugs to treat this, but if drugs are not appropriate, the other approach is to treat this left atrial appendage itself. And the approach that we most commonly would employ is to use this particular filter device. How does this filter device work? Well, a catheter is used to introduce this device into the left atrial appendage. Again, it's a single catheter. Once we advance the sheath, then we can withdraw the sheath and the catheter springs open into position. Once we know it's in good position and it's not going to move, then we can unscrew this as you see here, and then the device is deployed. Now initially patients stay on blood thinners for the first couple of months while this heals over, and once it heals over, then we can stop these blood thinners like Coumadin, and you just stay on aspirin after this point. This approach, by the way, this particular device is called the Watchman device, and there are other devices also that are being considered. I should again note, this is not an FDA-approved device. This is not yet approved for regular use in the United States, but it is something that we have as an option for patients as part of a clinical trial. And it's possible that this device may be approved sometime in the next year or so. There's another option called suture closure. The idea here is to introduce a catheter outside the heart. This is not surgery, but it's a catheter approach where we can introduce it outside the heart and loop it around the left atrial appendage, and then as you can see here, we tie off the left atrial appendage from the outside. This approach is also a very effective approach. We don't have as much data with this approach as we do with the Watchman device, but one advantage of this approach is that after we tie it off, one doesn't have to be on a blood thinner for any significant period of time. So this may be an approach that may be useful for you. Again, this is something to discuss with your doctor. So there in a nutshell is a description of what is atrial fibrillation, how can we treat atrial fibrillation, how can we prevent stroke in people with atrial fibrillation. And I hope this was very informational for you. If you have additional questions, I'd encourage you to speak with your physician about them. Thank you very much.